Good morning. Thanks you all for coming. We're going to talk today about health systems, health actors in low and middle income countries, and Christian organizations working with them, alongside them, to support and partner with them. The good news is that things have changed quite a bit for the better in recent decades. And I added this slide recently when I saw some of the questions that were coming in the poll. So thanks to those of you who answered that poll and got me thinking and adding some more information in here. One of the things that I started hearing about when I got involved in global health, which was a little bit later in my career, I had worked in other industries and communications, but I started in around 2007, 2008 in this field, and I heard about the child survival revolution. And that's something that there was a man who worked with UNICEF, Jim Grant, who had a real vision of how we could address this very large mortality rate for children under 5 across the globe. And he had 4 strategies, 4 low-cost interventions: monitoring growth, focusing on oral rehydration, because I know many of you probably know dehydration from diarrhea is one of the major killers of children, encouraging breastfeeding and immunization. And he got faith-based organizations, governments, community groups involved in this, and this was in the 1980s, 1990s, and it really paid off. Under 5 deaths dropped from 12.5 million annually to 4.9 million from 1990 to 2023. So that's very good news. And some other good news, there is he passed away, a Swedish physician and data visionary who looked at all of the health data to show how we were making strides in reducing poverty, improving health, life expectancy was growing. Also, as I just said, child survival was improving, and extreme poverty had been cut in half. And some other good news, you've probably heard more recently in the news about PEPFAR, the President's Emergency Plan for AIDS Relief, which was launched in 2023 by President George Bush. That was a real game changer. In the 90s, so many African countries were struggling. Almost an entire generation was being wiped out, and children were left as orphans, and the Bush administration saw that something had to be done. George Bush launched this program, and 20 years later, there's been 25 million lives saved, mostly in Africa, and so many babies born without HIV because their mothers were treated during pregnancy. So that's good news. And I just want to make a comment, especially since there's been so much in the news lately about USAID and government support. We're all hoping for change and reform with how U.S. government does foreign assistance. But one thing I'd like to highlight is that U.S. government programs really amplify the work of local actors, and especially or including Christian organizations. Okay, here is a couple photos from one of our members. I know I haven't explained my organization yet. That's coming very soon. So I'm curious if anybody here has any ideas about who this man might be, what is he doing, where is he going, and what motivates him. Is he a local healthcare a local healthcare provider. Yes, he's actually a pastor in the Philippines who was trained by one of our members called International Care Ministries. They work with pastors, local community groups, training them to provide some basic care in areas that don't have any other providers. So he is motivated by his faith, by his love for his community, and he's equipped with deworming medicines and vitamins, and he goes out into the community and distributes them along with other community health workers. Okay, why is faith engagement so important in global health, meaning faith-based organizations? 84% of the world's population belongs to a faith group, and faith leaders really influence community values, attitudes, and behaviors. And that's important in the United States, but it's also very important, and perhaps even more so, in many low and middle income countries. Faith actors often reach the last mile, meaning areas and communities that don't have access to other healthcare providers. And they have facility and community-based health services. They train workers and often respond to emergencies. A lot of times they're known to be the first ones on the scene, and I've even heard someone say the faith community has no exit strategy. They want to stay, they want to help people driven by their faith. And they also tend to focus on holistic health, treating the spirit, the mind, not just the physical ailments. Okay, now this is my organization that I work for. I've been there since 2012. It's Christian Connections for International Health. We're a network of 125 organizations, and those organizations work in 90 low and middle income countries. And we were founded in 1987, mostly as a small group of Christians that were meeting each other every year at the Global Health Council Conference, which is a secular organization. And that's why our name came from. It was Christian Conference for International Health. Over the years, CCIH started adding more programs, more things throughout the year, and became the organization that we are today. We have programs to strengthen local organizations' capacity. We convene a conference in the U.S. every other year, and then in those intervening years, we have regional meetings. We had one in Kenya last year. We'll have one in Southeast Asia next year. We also do some advocacy to the U.S. Congress and the administration on the importance of global health programs and engaging faith actors. Right now, we have 125 organizational members. 60% of them are based in low and middle income countries. They are local organizations, and the others are mostly in the United States, a few in Europe. 72% of them provide direct services in communities or facilities, and 42% of them are actually networks themselves. I'm going to talk a little bit later about how heavily networked health providers are in especially Africa, at least from our experience. Here are the countries where those members work. The darker color indicates a higher percentage. So even though those organizations are global, they are also responding in the US as well. We have a higher concentration that work in India, and as you can see, in lots of countries in Africa. And what we provide, this is a new framing of our strategy with visibility, quality, and fellowship. Visibility, lifting up the work of faith-based organizations by trying to map and count them, which has been a very difficult effort through the years. I'll talk a little bit about that later. We also provide, as I mentioned, advocacy, communications. We try to lift up the work of our members on social media, doing some storytelling. For quality, we try to help them strengthen their work, their efforts. We launched an organizational capacity assessment tool a few years ago, and it's a spreadsheet where organizations look at 10 different parts of their organization, leadership and government, and it has a scale of how strong they are based on if they fulfill certain tasks and have programs, communications, accounting, finance, their organizational strength overall. We also have a small grants mechanism focusing on boosting that capacity and the reach of those organizations. This is a fairly newer effort of ours, only happening over the last few years. We've had 31 projects supported in 30 different countries. And then we do some training. We have a virtual learning institute. We've had 2 years now, and both times focused on business development. The first was public grants. The second year focused on private foundations to help organizations apply for funding. And then fellowship, that's a very large part of what we do. I mentioned our conference and regional meeting. And all through the year, just about every month, we have some kind of webinar or meeting forum. We also have a weekly prayer guide so that we can lift up the concerns and praises of our members. And then along the bottom is a program called the 30 by 30 Health Systems Initiative, and I'm going to talk a little bit about that later. It's where organizations make a commitment to strengthen a part of the health system where they work. And we got the name 30 by 30 because we were targeting 30 health systems by 2030. The program launched in 2019, and so we just did a midterm review that showed the data of what those organizations have accomplished, and I'll also share that. Okay, we're also going to talk about who are Christian health actors, where are they working, how are they connected to each other, what is the scale of their work, and what we can learn from faith actors in LMIC. Okay, here's a little bit of an overview. We have Christian health facilities, training, the networks where they all come together, and I'll get into more detail about that, drug and medical supply, international support partners, health programs, community health programs, and then church-run or congregational programs. I'm curious if anybody here wants to mention any experience they've had, or what is your knowledge of any of these? Thank you. Okay, we had a comment from Pastor Saul Batista, and it's being recorded, so I'm just going to repeat a little bit. He is a pastor in southern Mexico, starting a health clinic and looking for some international support partners, and he emphasized how important having the engagement of all of the sectors of a health system. Okay, the first one I'll talk about, and this is what a lot of people, especially in the US, who may not be familiar with Christian health work in other countries may think of first, and that is the model of missionaries, medical missionaries from high-income countries going to Africa, India, other countries, and providing the health care. This was widespread in sub-Saharan Africa, and Asia, parts of Latin America. But over the years, over the decades, a lot of that has transitioned to local ownership, local control, so that they can be sustainable and to have respect for the local community as well, to involve the community more. Local churches, some of the local Christian health associations have assumed the management of those, where for the staff, governance, finances, but these mission partners may still conduct some training and provide other other support. And here's an example of one of those cases. This is a CCIH member. We call them the Lamb Hospital in Bangladesh, which originally stood for Lutheran Aid to Medicine in Bangladesh, but now it has local management, local control, and you can see here there's a shot from in the hospital, and then also they're doing a training on palliative care with local pastors. And here is another example. This is the Église du Christ au Congo in the Democratic Republic of Congo. They are an umbrella organization including a number of denominations, including the United Methodist Church, which is why you'll see that health worker there has the UMC logo on his vest. He's doing some testing for malaria, and also health workers are doing some outreach. There's some local children in a church program learning about malaria and how they can fight malaria and protect themselves. This Dr. Samuel sent me these photos. He's engaged with and works for this organization. Okay, now I'm going to talk a little bit about those Christian health associations I've been mentioning. I didn't put the figure in here. I think there might be about 30 of them in Africa, and what they are is the local clinics, hospitals, drug supply organizations, even training institutes have come together and formed an association. So the two examples I gave are the Christian Health Association of Kenya and the Uganda Protestant Medical Bureau. You can see CHAC is quite large with all of those 500 member clinics and hospitals, training institutes. We have partnered with CHAC on some projects in the past. One of them was working with local religious leaders to help educate them on maternal and child health, how to space pregnancies in a healthy way to protect the mother and the child. And we've actually also done something very similar with the Uganda Protestant Medical Bureau. In 2012, these networks joined together to form a network of all the networks. They're known as the Africa Christian Health Associations Platform, HAP. They're based in Nairobi, and they learn from each other. They have, and they can also talk to governments and advocate for more health in the local national budgets there for the countries. Here's an example of Uganda Protestant Medical Bureau at work. All three photos are from them. The first one, they're doing some testing in a Church of God clinic. The one in the middle, there's testing at a temporary community-based clinic or event. And you can see he has the logo of the Ministry of Health and UPMB, and I think they also worked with Novartis on this project. They also come to the houses in the community to do some testing, as we've talked about some of the remote areas and how difficult it is for people to access health care. Okay, here's another example of work of CCIH members. The first photo is with HAP, the organization I just mentioned. They partnered with a US-based organization called Restoring Vision, and they had a large eye health effort at the Presbyterian Church of East Africa Hospital in Kenya, where they did a lot of screening and gave out eyeglasses. The second photo shows World Renew partnering with the Africa Inland Church in Tanzania to demonstrate vaccine preparation to help people feel more comfortable with vaccines. There are community health workers there who are learning how the vaccine is prepared and administered. Okay, so now I have a question for you all. I am curious if you feel that there are many health networks that come together for partnership in the US, and how common are partnerships on health efforts like I just showed in other countries, how common are they in the US? I'm curious if anybody wants to comment on that. It's a common question, what is the scale of Christian healthcare across the world, especially in low and middle income countries? That's a great question. It's a very difficult question. We don't have an answer. So I guess I won't ask you to guess, like I said in there. It's an important question for many reasons. One is that Christian health efforts are sometimes left out in planning by their local governments, in some cases, and also by larger donors, because the scale of what they're doing is not recognized, not absorbed. So the efforts to measure global Christian health work started quite a while ago. In the 1980s and earlier, there really wasn't much sharing of data. So congregations or denominations that had mission work might have had their own data, but it wasn't shared with others. And then in the 1990s, the World Council of Churches, which is a global organization based in Geneva, they do more than health work, but they do have a health program. They started an effort to count, but it was really limited, and it was hard for them to map. In the 2000s, the early 2000s, PEPFAR, the program I mentioned earlier that fights HIV, also brought more attention to faith-based organizations because they were heavily involved in receiving those funds and working in their communities in Africa. So it brought more attention, and a couple of organizations, including the one I work for now, started some efforts, but it was fragmented. They didn't get as much done at that time. In 2015, The Lancet published a series of articles about Christian or faith-based healthcare, and they had some estimates, mainly the 30 to 70% in some countries. There wasn't a way to say how much was in the whole world, but they had some estimates based on what they were seeing. In 2022, CCIH partnered with a few other organizations I'm going to mention in a minute to form the Christian Health Asset Mapping Consortium. And I'll tell you about that. So we worked with HAP in Africa, the Catholic Health Association of the US, the International Christian Medical and Dental Association, ICMDA, the Dalton Foundation, and the World Council of Churches to launch, we call it CHAMSI, the Christian Health Asset Mapping Consortium. And the main thing we've done in those 2.5 years is, I would call them snapshots of data. We launched a hub last year that's a registry of data sets, and that there's still a long way to go, but we do have some data sets on that. But the main thing that we've done is publications that are mapping studies or data collection, so that you can get a picture of part of the globe and what is happening in there. So the first product that we released was the Sub-Saharan Africa data brief. We did that in May of 23, and we took data from 22 Christian health networks in 17 countries and counted, with their support, obviously their help, found hospitals, health centers, community programs, training institutions, and drug supply organizations. So we're hoping that through time, as we collect more and more of this information, we'll get a stronger picture of what is being done by Christian organizations in low and middle income countries. Another one that we released this last year, was focused on community health programs. And they're doing a lot of different things. These are Christian community health programs, nutrition screening, disability services, family planning, mental health, helping people navigate their healthcare system. They might be run by churches, hospitals, local clinics. Sometimes they have government support, or they might have support by other donors, private donors. They may be staffed by community health workers, clergy, and other healthcare professionals. So this study was done by contacting 168 faith-based organizations in not just Africa this time. It included India, Latin America, other countries as well, and found 30 of those operated community health programs, and actually sometimes multiple ones, so for a total of 208. There was no way to count how many community health workers there were, because those numbers are just, it's very hard. It's also very fluid as people transition in and out of those type of roles. Here's a list. I know it's hard to read, but this is in the brief, and shows the list of organizations that have those, how many programs they have, and the countries that they serve. I also saw in the brief a live database of countries that I thought was interesting, of countries with accredited and salaried community health worker groups. And I can share any of these links afterwards. Just wanted to give a few examples of the community health programs that were found in this effort. There's one, the first one, this is ACHAP. Again, that's the Africa Christian Health Association platform. AFYA, I don't know how to pronounce that. That's the Swahili word for health. This program was supported by USAID for 3 years, from 21 to 24. And there were 1,300 community health workers trained in this project, and including community leaders and faith leaders to support health services. And so while the program is over, we hope that their training has enabled them to continue their work. This next one also is a CCH member, Amos Health and Hope, and they have 23 community health promoters that were trained on care for childhood diseases, maternal health, WASH, when to refer people to clinics. And they cascade trained to 300 other community volunteers. which were able to serve over 28,000 people across 25 communities. And this was supported through a variety of private funders. The Christian Aid program in Iraq, they have 10 community health programs, and you can see here what the type of work they do, preparing families for their harsh winters, hygiene and sanitation work, and they also have mobile medical clinics treating chronic diseases in a number of villages there. Again, this was private funding. Two more, one in Guatemala that focuses on nutrition, providing meals, teaching gardening and crop rotation. And then the Emmanuel Hospital Association in India, they're also a CCH member, and they're a network of hospitals and community health projects in northern India. They have a strong emphasis on discouraging child marriages through their program, human trafficking, mental health, providing disability services. And they have a very large reach. Every year, their community health programs reach 4.4 million people, and lots of different areas that I've mentioned in there. Okay, this brief we just released last week. It's on Christian health worker training institutes. We had 2 health system experts, they're volunteers, early retirement phase, and they were great. They did a lot of research, internet research, found 1,365 Christian health worker training institutions. Those are medical schools, nurse training programs. They found 3,800 degree programs. If you look at LMIC, there are 634 institutions. And medical programs were 12% of that. Nursing was the bulk of it, 39%. They also have oral health, pharmacy, behavioral health. And they found here's the medical schools. The darker, of course, means more. The countries they're located in. These are nursing institutions. You can see where they're located as well. The program that I said I would mention it's a commitment maker model that we had our 30 by 30. And we launched this in 2019 it's really a commitment maker model where organizations commit to strengthen one of the sectors in their health system, such as workforce, leadership and governance, service delivery, medicine access, information systems, and financing. We added community services to that. Those are the WHO 6 building blocks of health. We added community services because, as you guys know, that's so important. And the idea is that they commit to specific things and they get approved into the program. There's not a financial incentive for them from us, but it encourages them to set goals, to do monitoring and evaluation of their programs. So halfway through the program, which goes till 2030, we did a midterm evaluation last year, and this is what we learned, that as you can see, the statistics are we're very happy with them. Over 11,000 health institutions supported through this program, over 8,000 training programs delivered, 61,000 health professionals trained, and 6 million people reached by the program with some sort of health service or education. And you can see they established community groups, church groups, involved almost 4,500 church groups in health, and established over 1,000 community groups that weren't already existing as part of the work that they did. They also trained many of those community groups. Okay, let's come back to Pastor Emmanuel, who I showed at the beginning. International Care Ministries in the Philippines is a CCIH 30 by 30 commitment maker, and what they do is, in their program or their commitment, they train community health workers, they call them champions, to conduct some kind of health work in 24 different provinces in the Philippines. They have a phone app that they can provide public health education, screen for illness and malnutrition, and track health indicators, and also refer and track those referrals to higher level facilities. They provide this service in areas that are often very remote, and what ICM found that 70% of the deworming for children in those communities was coming from the ICM community health workers. Okay, what can we learn for and from the US context? So one thing about that I've observed, and I talked about with other staff, in low and middle income countries, often the advantage that faith-based services have is that there's such a strong connection with the community. Faith leaders have a large influence on many choices that their congregants, their community make, including health, because they are trusted messengers. And as I mentioned before, 84% of the globe has identifies with a religion. There's also a strong sense of community in many of these low and middle income countries that make some of these community health programs stronger. And task shifting in low and middle income countries, meaning like traditional birth attendants that can be trained to provide skilled care where a woman otherwise would not have any. There's more of that in low and middle income countries. Also, there seems to be a lot of partnerships among organizations in low and middle income countries, less siloed work. I'm curious to hear what you would say about the US. I don't have, except for my own personal experience navigating the health system, I don't have professional experience in it. Another comment that came from another staff member was that often in low and middle income countries, there are a small amount of key or dangerous health issues that the health workers become very well versed in, but they might have less knowledge of a broader range of health problems that could happen. And there are also very strong health networks in some areas and countries, such as Africa, as I mentioned, and they can give them some discussion and bargaining power with their governments. We have a question with the recent shutdown, freeze of foreign assistance. How has that affected our work? It's been very tumultuous. It has also been very confusing because when it was a 90-day pause, then it was a almost complete shutdown, and then there was a waiver program where organizations could apply for a waiver, but so many of the staff they would be applying to were on administrative leave, and it was very hard to get answers. There's a lot of product, including medicines and even food that was just frozen because staff was not able to go get it and distribute it. So we're hearing that from our members. And then then some of them got termination notices of their grants, and then those termination notices were rescinded. So it's been very confusing. Our organization did have a relatively small U.S. funding portion, but that is, like I said, is a small amount. So it didn't affect our staff and what we were doing at the time, but it does affect us because we've really tried to get their stories out there. We're doing some advocacy, and some members are willing to write something, and others are concerned. They've been told even by their own governments or by U.S. officials not to talk about it. So, yeah, it's been... So I think, and I'll say that I think many people, almost everybody working in the sector has known that there is need for reform. We want more local control, obviously working to be independent, and building the capacity of local organizations. But the abruptness of the terminations without giving them like an off-ramp time to get other sources, to change processes, and it has been very concerning, yeah. So the question is community health worker training in the U.S., and I assume you mean to then go off to, actually, yes. I don't know of community health worker training in the U.S. for people who are going to work in the U.S. I don't. Yeah, some of these, I was just doing some research because the only one, a lot of the questions that came in were about sustainability and funding. And so some of the things that we have talked about, like impact investing, is just very new to us. We haven't gotten involved in it yet. So I was doing a little bit of research and added. But so yeah, the question is small countries that larger organizations are hesitant to invest in because they would not be reaching as many people. I think my first thought is to see who might be, that in our network might be involved there, and I'm happy to do that, and I'm happy to give you one of my cards. That is, like you said, is very small. I have not heard of a Christian Health Association there, but I do know that as the Christian Health Associations are establishing in new countries, there's an effort now in South Sudan and other countries in Africa. Maybe not that one, I don't know. But I think helping them get connected, and by them, I mean anybody providing health in those countries with other providers and a regional network is valuable. So there was also a question about how the doctors are trained, and I think I addressed that with the health worker training institutions slide we talked about. How many providers? This slide, I just did some research about how many providers there are, but they mean the health practitioners. And helping the underserved, how I can be of service, somebody asked that. It depends on what you're looking to do. If you are a practitioner and want to serve, actually go to another country. There are some organizations. And again, I'm happy to try to connect anybody or help you find those. And how to effectively partner with the local church. That was another great question. I think World Relief and the Aruka Network, which are both CCIH members, what they do is they form clusters of churches, and they make sure that whatever they're doing, the community has decided that that's what they need. Something I hear often in this work is nothing about us without us. So involving the local community, making it community-driven, so that they are solving the problems that are most important to them. And affordable, this is a huge question. How affordable are service? What is the income, health services, and what is the income level in LMIC? There's such a blend or a diversity of how different countries, what happens in different countries. Christian hospitals and clinics might have subsidized care supported by donations. A lot of the governments, or some governments in Africa, fully fund some of the most dangerous problems they have: TB, malaria, HIV. Those services may be free. There was a question about the average income. I chose 2 countries just to give a sample. Malawi, which is one of the 10 most poor in the country, has an annual income of $464 per person, whereas Ghana has moved from low-income country to middle-income country status quite a few years ago. So there's a diversity there. And evidence-based practice. Probably about 10 years ago, a journal was established, and actually our executive director was one of the people who established it, called the Christian Journal for Global Health. It's a great publication. I think it might be quarterly, and it's free online access. They do evidence-based, peer-reviewed articles. Some of my colleagues have been published, so if you're interested, I would check that out. Thank you. Thank you.